To Alan and for the network for having organised today's event. This is an area that I think we're all passionate about. We do need to reduce alcohol use problems in our young adults. You can see that I'm working with Deakin University here in Australia, and I'm the chair in health psychology. My work also extends into work that I do with the Centre for Adolescent Health, which is part of the Murdoch Children's Research Institute here at the Royal Children's Hospital. So it's a very large research institute looking at children. And so I acknowledge that much of what I'll be presenting today I've learned really working with researchers on that campus. So they're a great group to work with, and I hope I'm sharing information that you'll also find valuable. Today, what I'm going to be talking about, obviously wearing the hat of somebody who's looking at it from the research lens, looking at I want to show us how rates of alcohol use with our youth compares from Australia looking at the United States. For those of us sitting in New Zealand, I think that the rates in New Zealand would be comparative to those in Australia from everything that I've read. But I think we do need to compare ourselves to the United States, and I'll explain why as we go down the road. But basically, they've just done an enormous amount of work looking at preventive solutions, and it's for that reason that I think we just need to take note of what they're doing. Then I'm going to look at how we can compare our young adults, because I think obviously adolescents grow up to become young adults, and looking at solutions in both these population groups is obviously an important foci today. So the study I'm going to talk to you about is called the International Youth Development Study, and this one is a study that Deakin University is involved with, the Centre for Adolescent Health, and we've been working with colleagues at the Social Development Research Group at the University of Washington. So a great opportunity to work with researchers around the world. Now here we have Australia and New Zealand. Obviously we're concerned about the Pacific regions, but we're today thinking about how we compare over there to our North American colleagues. And this has been the point of the study. The reason that there's obviously been a huge investment in research that we just can't ever hope to match. It's been made in North America. But one thing that we've tried to do with our study is to just check how the development of children compares in Australia compared to North America. And that helps us to understand whether or not some of the various measures they bring in may be relevant for us here in our neck of the woods. So the study is one that was done in my state of Victoria, and we were comparing to Washington State in the United States. And you see that in 2002 we recruited children in grades 5, 7 and 9, so they were state representative samples. Large samples. You can see that there were within the schools that were targeted almost 4,000 children in both states, of which 3,000 came into the study. So really an excellent recruitment rate. 3 years later, we still have 98% of the study participants in a longitudinal profile by 2004. That's two years later, sorry. So really an excellent follow-up rate, one of the best in the world. Working with the US team, it really helped us to learn some tricks of the trade about doing good research with children. You can read more about us in this paper, and I'm happy to take email or comments from people if they're looking for information on the study. The main point to make is when we compared Victoria with Washington State, you can see here in the grey that the number of children reporting that they were having harmful alcohol use was much higher in Victoria relative to Washington. Also, alcohol use itself was very much larger, with it being, you can see that the effect size was 0.6, so quite a large difference. And that a lot of this was related to children saying that their parents supervised their alcohol use. We actually found that was a risk factor if that was done in year 8 for children going on in year 9 to more harmful use. So our study doesn't support the practice of trying to supervise the young people's alcohol use at home as an effort to try and reduce the problems. In both states, it seemed to be a risk factor for increasing problems. The young people told us that their parents and other members of the community they thought were favourable to young people using the alcohol. So this was an issue that the study needed to address. And you can see that the rate, in fact, was very high, even at the start of secondary school in grade 7, for children in our state of Victoria using alcohol. In Washington, they were high on substance use problems in the family. So what we learned from the study is they seem to go into treatment at a much lower threshold of substance use in the US than Australia. And the young people were saying that their parents tended to know what they were doing a bit more. And again, that was something positive in the US. So there are our findings for differences. You can see that it wasn't very favourable to what we're doing in Australia around youth and alcohol. So talking about possible solutions, from this part of the study, we thought that really what we have to focus on is delaying the age of first use of alcohol more and try and bring ourselves a bit more in line with what our counterparts are doing over there in North America. We need to encourage parents to move away from this idea of sort of trying to supervise the alcohol use and maybe just set firmer rules discouraging the use. And then also there was we need to use social marketing and other means and enforce the minimum alcohol purchase age and drinking laws. These all have evidence. I want to point people to this website for communities that care. This is a not-for-profit company that's running under the Royal Children's Hospital here in Australia, and it offers a chance to be able to get evidence-based information about what you can do at a community level. And here's more details about the partners involved, including the University of Washington, my own university, and we're working with the campus there at the Royal Children's. Going back to the International Youth Development Study, we've now done a follow-up into young adulthood, and we've had an excellent response rate. 84% were retained. This was supported by our National Health and Medical Research Council and Australian Research Council, and this was done in 2010 to 11. I'll just stop to draw wind for a second. I'll ask you, Alan, how much more time do I have?
Sorry, John, you have about another 5 more minutes.
Thank you very much. I just wanted to make sure that I was not eating into the time of other speakers, so I'll press on. Talking now about what we found when we followed up 10 years, just under 10 years later, this a sample, I'm just talking about the Australian sample that we followed up in Victoria. And we're asking ourselves, how do the rates of the young adult alcohol and drug use, again, compare to the large studies that they've done in the United States? Here, what we're comparing to is their school surveys. And what we found was actually that even after age 21, that the rates of alcohol use in our state of Victoria are still higher than in the US, and this keeps on going even into older ages. So here we're comparing with the Monitoring the Future study in the United States with our follow-up data from the International Youth Development Study in Victoria, and these are the 95% confidence intervals. We can see that at 19 to 20 there's quite a large difference. It falls off a little bit later on, but it's still significantly lower rates of alcohol use in the US. The other surprising finding was that we found our high rates of young people using alcohol in Victoria, our rates are very similar to the rest of Australia, actually associate with higher rates of tobacco use. You can see that tobacco use was consistently higher in Victoria relative to Washington State. And marijuana use was in some cases higher in the US a little bit, but we were running fairly close, apart from this one here, a little bit older. But other forms of illicit drug use were actually higher in Australia. These are the LSDs, cocaine, volatile substances, stimulants. A lot of it is driven by the stimulant use that's very high in Australia. So we didn't find that our young people were particularly protected from illicit drug use by the fact we're so tolerant around their alcohol use. We also wanted to know a bit about how harmful the use of alcohol is for our young people. Now these are, bear in mind, fairly state representative samples. You can see the questions here that we were asking. That's the audit, which is a widely used instrument to look at alcohol-related problems. And you can see here the distribution of the scores. Most people only score low on the symptoms, but there is a tail extending out to people with quite severe problems. These are the averages on the instrument. Now, I'll just say that a score of 8 is considered to be problematic, and it is concerning that the males in Victoria, on average, score above the problem score zone. When you actually score at 8 or more problems, more than half the males in Victoria have problems, and you can see that 43% on average have problems with alcohol. Now, that's across the whole population, and it's a very good estimate. So this is a real issue for us. Finally, looking a bit at some of the factors that contribute in young adulthood to these problems, we studied the young adult context of use in best friends, intimate partners, workplace, watching sport, even in socialising. These are the sorts of questions we asked whilst we were asking about the workplace, looking at acceptability of alcohol use and whether or not there'd be what sort of attitudes to drinking being under the influence at work that your workmates might have. And the results basically show that this is quite a good measure, that the alpha is 0.79. The mean was 1.6, so it's getting up to being towards the sort of not discouraged, which is very important finding. That we find that it's not acceptable is not the score that we would have been expecting many more to say it's not acceptable. And where it was that people were reporting some of these results that it was tolerated, that's actually quite highly correlated, 0.38, with your problems with alcohol. So we've got a good measure of workplace approval. It's showing that not enough people in Victoria are saying that it's not acceptable, and it's highly correlated with the problems they're having. Here we see the correlation when we look also at their own consumption even is higher at 0.52. So we need to be focused on the environments. Evening socialising, do you see people drinking? Do you see them drunk? Is it likely when you're socialising that alcohol will be available? Is it likely that people would be served alcohol? And really our findings showed that, again, this was all too common and, again, fairly correlated with problems with alcohol at 0.38. So, again, another area that needs attention. We did finally a regression seeing what predicted having problems with alcohol. You see a fairly large sample, over 2,000 here. And those predictors were you're a bit protected if you're female. If you go living in a rural area, you're a bit more at risk. If you were using alcohol frequently as an adolescent, then that's a risk factor, all things else controlled for. If you leave school early, that increases your risk. Some of these are the usual suspects. Here we found that if you were living with parents, that was a risk. If you're living with friends, it was a risk. So really, other living contexts are better. And then all these things we measured in the socialisation environments were all risk factors. If your peers were tolerant or using, your intimate partner, if in the workplace you're in a place where these things were tolerated, your socialisation environment and where you watch sport all contribute to your problems. So the solutions that come from our study, not from our study so much, but increasing the price comes up from a lot of studies that needs to be one area. Age 21 laws that operate in the US, our study's favourable to those. Restricting alcohol availability, so again regulating the use of alcohol in where you study, where you work, in your sports environment, where you socialise, and again going back to delaying the age of first use to reduce heavy adolescent use. There's my email address, which I'll leave up, and Alan can tell me whether we've still got time for a question or two.
Yeah, thank you, Laurie, and thank you for a really informative presentation. One of the questions I think has already been answered, but I'll still read it out to you. What are 2 or 3 things that you would like to see policymakers do to curb alcohol-related harm, particularly with young people?
What was interesting, he said, one of the risk factors for young people drinking.
Oh, sorry. Sorry, John, did you hear that?
Yes, if you could could you ask me that question again?
Yeah, sure. What are 2 or 3 things that you would like to see policymakers do to curb alcohol-related harm, particularly with young people?
I think there's a few things we can do. As I say, I'm actually in favour of an older drinking age. I think that we need to look at this one, and policymakers should consider that. I know that when we look at the evidence for the developing brain, that we really don't have full brain maturity at age 18. So I think the drinking age needs to be older than that.
Yeah.
The US, where we were comparing to, they have the 21 drinking age, and you could see that on most of the measures we're looking at, we're finding that they actually seem to be doing better with alcohol and alcohol-related problems. So that's one thing. The other one is, I think if we're going to have a minimum drinking age, we should enforce it. And that would mean that we really shouldn't be so tolerant about kids using alcohol under the legal age. So, and I think that can be done by checking sales and also marketing to parents a stronger message that it's okay to not be tolerant about kids using alcohol.
Okay, John, thank you for that. There will be some other questions which I'll save until the end because I'm conscious of our time limits here. But thank you very much, John, for your wonderful presentation.
My pleasure.
Good. Okay. I'm now going to come back to my screen. And we're now going to move on to Dr. Ruth Barker's presentation. And remember, this was recorded. And so I'm just going to play it in its entirety. And if you do have questions, Ruth is more than happy to share them, to answer those questions with you and share them with the rest of the audience. So the first few seconds of this movie will be black, but then it will then go into her presentation. So just bear with me for one moment. Thank you.
Event to the webinar today. As Alan said, I direct the Queensland Injury Surveillance Unit, and I work as a paediatrician at the Mater Children's Hospital based in Brisbane. The Injury Surveillance Unit's been collecting data since 1988, but we currently have a data set that goes back about 14 years with 600,000 records in it. And although I'm a paediatrician based at the Children's Hospital, we do collect paediatric and adult data. And what I'm going to present to you today is information that we've been trying to collate around drugs, alcohol and violence in our emergency data, injury surveillance data set. I think the first thing I'd like to point out to everybody, if you're not ED clinicians, is that alcohol-related injury is pretty obvious to all people who are working in the emergency department. That's largely because people, when they're intoxicated, behave in a really predictable fashion and they smell like they're intoxicated. Having said that, this type of injury is really poorly quantified using the emergency department information system data, and it's also reasonably poorly quantified in the inpatient data. The intoxication codes that we have available for identifying alcohol-related injury in the emergency department aren't usually applied to the majority of patients who present with alcohol-related injury. And by that I mean that when patients present and they're just intoxicated, they get an intoxication code. But if they present and they're drunk and they've done something else to themselves, then they get diagnosed with a code that doesn't reflect that. So they may get coded as head injury or fractured wrists or whatever. Unfortunately, the problem is even more significant for drug-related presentations, and that's largely because they're more difficult to identify clinically in the emergency department. And the majority of patients that we're able to identify in our ED data set who have presented with drug-related injuries are those who presented with overdoses. And we have a range of ICD codes that we can use to identify drug overdoses, but we don't get a lot of information about people presenting with other injuries where they've got drugs on board. Drug testing in the emergency department isn't really standard, and sometimes even if we do it, we don't get the results back until days or weeks later. So it's underrepresented in our data. The violence-related injuries are reasonably well coded up in our injury surveillance data, but probably a little more difficult to identify in general emergency department routinely collected data. We've been doing a lot of work at QISU trying to explore how we might improve identification of drug, alcohol and violence-related injuries. And we've been exploring a lot of the triage text that we get when we get our data set. We've been identifying drinking terms, drug terms and violence terms, and it's this work that I'd like to present to you today. Here you can see a list of keywords. So these are words that appear grouped up by the different categories in our triage text. So I haven't presented the full list of terms. As you can see, we've got about 1,052. And you may ask why we've got so many triage text terms, and that's because triage nurses are very inventive typists and spellers. So a lot of these terms reflect typing and spelling variations. But we've been working on using generic alcohol terms, alcohol brands, consumption terms, intoxication terms, and there's a whole lot of slang that goes into that. So, for example, in Queensland, if you're drinking beer, a lot of people type 4Xs, which is the local brand, and I guess if you're in Victoria, it's BB. So we have to be quite inventive about looking at the different terms that we're using. The same goes for different intent terms. So we have a whole lot of words that come up in relation to assaults, and usually those terms are around what other people are doing to each other, so bite, kick, punch, and that sort of thing. We use police involvement as a flag for violence-related issues, and so on. So we have been working on expanding this list of text terms that we can use to grab a whole lot of injuries in our data set that are related to drugs, alcohol, and violence. Then, unfortunately, we need to go through and see how specific those terms are. So what we have is a whole lot of sensitive terms of picking up issues, but many of them aren't terribly specific, and we've been working on trying to develop a list of really specific terms. Or the other thing that we've been working on is if you have one or more of these terms that come up in your triage text, then the likelihood that you've presented with an issue that relates to drugs, alcohol and violence in the ED is higher. So the minute it says something like Bundy, which is Bundaberg rum, and pub and punch, then we know that there's alcohol at least and violence at play. This is just a breakdown of the age distribution, and the data I'm presenting here is actually from one community for 1 year. So it's a snapshot and there's no trend data that I'm going to present. The age distribution probably wouldn't surprise most of you who work on this particular issue. So the majority of patients that are presenting with drug, alcohol and violence issues fall into this 18 to 24-year-old age group, with males roughly presenting at twice the numbers as females. What might surprise some of you is this group here of 15 to 17-year-olds. And there's been a lot of talk in the alcohol area, particularly about licensed venues and young, particularly males out at licensed venues and glassing-related injuries, and that's what seems to have everybody's focus. But this group here are still being injured with issues relating to drugs, alcohol and violence, but they're not at a legal age to be in licensed venues, and that's not where they're being injured. This, again, for people who work in the emergency department, this slide comes as no surprise, and it just shows the time frame of when this group of patients present, ranging from 6 a.m. to 6 a.m. the next morning. And as you can see, the bulk of the workload occurs here overnight from about 10 p.m. onwards. The orange line here is people who've presented with drug and alcohol related issues. These are cases where we can identify drug and alcohol using the triage text. This is the group of people down here at the bottom where these are just the violence-related presentations where we couldn't identify any drug or alcohol association. Some of the work that we've been doing is based on a previous bulletin that we published looking at just alcohol-related injuries, and we've expanded our categories to try to look at drug and alcohol-related assault and then assault where the drug and alcohol issue is unspecified in our data set, and the same with self-harm. And as you can see, we go down to road traffic crash where drug and alcohol is associated, and then alcohol-related injury where there's no violence or assault associated, and then other violence-related injuries where drug and alcohol is unspecified. And we can start to build up a picture of the sorts of presentations in this particular community. This is a Venn diagram. This is a Venn diagram just showing the overlap between alcohol, drugs and violence. And you can see the quite significant overlap here between violence and alcohol, and that's probably not unexpected for most in the audience. This group over here of drug-related presentations, you can see it's a much smaller number with sort of less overlap, and I believe this is largely because of the difficulties we have in identifying this particular issue in our data set. And this is the same data presented, just expanded out a little bit with intent of injury expanded. What I'd like to draw your attention to here is particularly this violence to object, and it's only a very small group. By violence to object, we mean people that punch walls and kick chairs and that sort of thing. What we find when we look at our drug and alcohol related data set broadly is that these violence to object patients are often the younger male patients, so often the under 18-year-olds. And it seems from looking at our data that these guys then progress as they get older to not punching objects but punching other people. This again is the assault data that has been expanded out by the different types of things that people do to each other. And you can see the information at the top has assault with drug and alcohol identified and assault where drug and alcohol was not specified. What I'd like to draw your attention to here is the cutting piercing group. This is your glassing group. So there is a stabbed underneath here, but stabbed generally, when we've coded that as stabbed, it means that someone has used a knife or a screwdriver or some long, sharp implement. So the person who gets hit in the face with a glass will fall into this cutting piercing group. It's not a very big group. We've just had a paper accepted for publication which shows that it's probably about 8 to 9% of assaults in the broader Queensland data. In this particular community, it's not such a big group. But you can also see down here where it says drug and alcohol not specified, the cutting piercing group is the same. So if you wanted to look at that particularly in this particular community, you could then start to try to drill down and look at the location where these events are occurring. Are they occurring at home? Are they occurring in licensed venues? And this again is the assault information, all of the assault information, so nearly 1,200 cases, but broken down by age group. And again, you can see this large representation using the of the 18 to 24-year-olds. You may also note in here that we've got some sexual assault cases and spiked, so it allows you to look at which particular age group is vulnerable to those particular types of injuries. And even though they make up a very small group in this particular community's data, it may be that that's something that that community might like to focus on because of the age of the people who are involved and the gender and the long-term implications of these injuries throughout the rest of their life. In this community, they were collecting our injury surveillance data just using triage text alone, and it's a little bit of a different technique that we've been exploring in our earlier communities who've contributed data. They've been using coded fields as well. And one of the big deficiencies in this data set is that they weren't collecting a lot of textual information about the location where the injury occurred. So you can see that the majority of cases, we didn't actually know where those injuries were occurring. In the issue of drugs, alcohol and violence, this is quite a complex issue about where the injury is occurring because it opens up a lot of other questions about where are they when they're taking drugs and drinking to excess, and a lot of conversations that I had yesterday at a conference about people preloading or popping something before they go out to a licensed venue, and then the injury actually occurs in the licensed venue where they're interacting. Interestingly, the proportions that are demonstrated on this slide seem to be fairly true for what we've been able to tell from our statewide data, where roughly 40% overall of at least alcohol-related injuries are occurring at home and only about 15% are occurring in the licensed venue. But as I said, that doesn't indicate that that's where all of the drinking occurs, and it's possible that some of the drinking occurs out and then people go home and are injured, or vice versa. And finally, in this particular community, we just had a look at whether we could tell whether the police were involved with the patient prior to coming to the emergency department or actually escorted the patient into the emergency department. And you can see that the police In this particular drug, alcohol and violence data set, the police were involved in just a bit over half of the cases. The no police involvement, it may be that the police were involved but it just wasn't recorded in the text, or it may be that the police weren't involved at all. And you can also imagine that there might be a whole other group of people where the police were involved because there was drugs, alcohol and violence, but the patient wasn't sufficiently injured to present to the emergency department. So when we start building up a community picture, we realise that there are more aspects to the story that any one group sees in the community. So I spend a lot of my time trying to talk to emergency departments and get them started collecting data. And I always have to ask myself the question, why bother? Because as I said yesterday, injury surveillance data collection is about as popular as gonorrhea, but only half as fun to get. And the issue is that solutions around this particular problem require collaborative engagement, and engagement requires a shared understanding. And as I said to the guys yesterday at the meeting, if you go out to regulators and people in the licensees in the CPD or police, if they don't understand what your life is like in the emergency department, then we've only got ourselves to blame, and we need to be able to present this data broadly and get people to understand what we're actually seeing in the emergency department. And not every emergency department needs to go to the level of collecting injury surveillance data. So Cairns has a unique pop-up where when an injury code, diagnosis code is entered, the pop-up comes up and it asks, is this injury related to alcohol and did the injury occur in the CBD? Two very simple questions which once the registrars are trained up, they can answer it. And there's a group been working on some more sophisticated mapping of where violence occurs around the Cairns CBD and trying to take that back to the community. So this is very powerful information that can be shared with the community, and it can help you address issues that are relevant to your community. And I'd like to close there, and unfortunately I'm not available for questions today, but if anyone would like to email me with any questions, I'm more than happy to answer them. Thank you.
Thank you, Ruth, for that.
Thanks, Alan, and thanks for the opportunity to present to the webinar today. As Alan said, I direct the Queensland Injury Surveillance Unit, and I work as a paediatrician at the Mater Children's Hospital based in Brisbane. The Injury Surveillance Unit's been collecting data since 1988, but we currently have a data set that goes back about 14 years with 600,000 records in it.
Sorry, folks, just a little bit of a glitch there. We're now going to hand over to Larry Gebetes, and he's going to talk to us today about, given some tools, what can we do to make a difference? So I'm just going to hand back over to Larry. So bear with me for Laurie, I should say, for one moment. And Laurie, are you online now?
I am, Alan, yep.
And can you turn your webcam on, please? There we go. And it's over to you. Thank you.
Thanks very much, Alan, and good afternoon, everyone from New Zealand. I want to talk this afternoon about three things, and it was interesting listening to what Ruth had to say, and I also said to Alan just before we came on air that you sometimes think about the issues that we're dealing with in New Zealand aren't impacted in other places, but I just picked up something from a news feed that I'm on, or a network that I'm involved in, where there's an Alcohol Policy Alliance in New South Wales is holding a community forum to look down to break down the barriers to community involvement in liquor licensing in New South Wales. So I guess I'm going to talk a little bit about that further through, but also to follow up some of the things that Ruth talked about and John talked about the evidence to inform the issues. I also want to talk a little bit about working across the sector, and then given some new legislation in New Zealand, how the legislation can help and how communities can access that. So my discussion really is based around 5 things. First of all, many who are listening probably know that I come from a fairly long background in policing, and my last 10 years were at police headquarters operating around areas of alcohol-related harm. I work for local government and spent a lot of time looking at the development of licensees forums and other issues in Wellington City. And I was also a member of the local government alcohol advisory group, which was part of the development of local government's response to the new legislation. I've carried out a bit of review of work in communities, and my comment about that is that often communities are putting, first of all, putting things in place that are not very strongly based on any information at all, or alternatively are putting in something in place that's completely unrelated to the problem because they have a perception of something that's there that isn't really there at all. And I'm also involved with Local Government New Zealand in the Know-How program, which is to work with local government delivering workshops around the changes to the legislation. I think the important thing around reliable evidence to inform the issues, and I think Ruth's given us a really strong picture of that, and so did John, but from a practical perspective around an emergency department, some of the statistics that we do get don't actually give us a very clear picture. And that's certainly an example around some of the police data that we currently get in New Zealand, that it just tells you that there are certain offences that are alcohol related, but of course they can have a blip over one night and suddenly that percentage is pushed higher, and it's not really what the problem is about. And often it's only from one source that people are taking that information. And we've seen examples of that, about initiatives that are being promoted around the change to the legislation in New Zealand, and are selectively taking one piece of that information, yet in actual fact there's no evidence to show that that's making any difference, that it requires a collective response around a range of issues to make a difference. I think also that we've seen a growth in the number of pieces of information available based on population. And in New Zealand, we've seen things like ACC and to a certain degree some of the police statistical information that starts to show the issue based on per 10,000 of population. I think that paints a clearer picture of what the issue is, and it can then be comparable with other places, and it helps that to work. We're also now seeing, and I think it's really important, that more of the data is being triangulated. And I know that some of the work of Catherine Graham and Ross Hommel, based around their book Raising the Bar, talks a lot about that triangulated data, and it does start to give you a greater picture. And Ruth emphasised that, I think, around the difference between what's happening in the emergency department and what's happening with police. And I recall a piece of work that was done out of Griffith University in Queensland, looking at the number of alcohol-related assaults on the Gold Coast that were reported, and only 1 in 4 of those reported, or 4 that were reported to ambulance, only 1 of those was actually reported to the police. So having that broader base of information, trying to triangulate that data. And I think that's also coupled with the fact that there's a real push, I think, to try and move what we call in New Zealand that alcohol-linked data or last drink survey away from the last place of drinking to having the first place, the most, and the last, to give a better picture. That's another example, I think, of triangulating that data. I think often it points to something else as the problem. I think that if we get the right data, we find an example, and completely unrelated to alcohol, but an example I had in one of the communities that I did some work in showed that everyone was complaining about youth offending, but in actual fact most of the offending that was reported was happening between 12 midday and 4. So the problem really was truancy and not the issue of offending. We've seen a little project occurring in the part of New Zealand that I live in, where the ambulance have started recording data around alcohol-related offending, and that coupled with some of the other data is painting a very interesting picture. And in particular, it's showing that the largest number of calls for service by ambulance are not, as Ruth pointed out earlier on, not to the likes of licensed premises in the public place, but actually to home. And I suppose that supports some of the information we get around the front loading and side loading and some of the stuff that's going on in the community. And I also think that we need to look at some slightly different ways in gathering that information that identify both the issues and success. And the best example I can give of that is I was talking to a taxi company a little while ago looking at some successes around a program that had been in place and asking them whether they thought intoxication had, whether there was less intoxication. And their answer to that was yes, because they had less soiling in their taxis. So there are other ways of perhaps determining that from the traditional ways that we've probably used. I don't think I need to spend too much time saying that working together is the way to go, and I think that that's already been alluded to. And I was reading an article yesterday that talked about working with stakeholders as being the cornerstone to best practice, and that if we don't do that, it won't work. And particularly around alcohol and particularly around licensed venues, that work needs to be very much involving licensees. And I know that traditionally, certainly from my first experience in this area many years ago, we didn't talk to them as they were seen as the enemy. But a piece of work that we did setting up a licensee forum in Wellington, we invited a group from the Melbourne licensee forum to come across. And they said they made no progress in changes to King Street until they actually were part of the solution as well as identifying the problems. So I think that they are really important, and working with them, communities can make a difference. Accords or forums, they have mixed results, I guess, and some of them have waxed and waned a bit, but they're a good way of bringing those groups together, and that might be one of the answers. And I know some recent work that we've done on a couple of communities, they've seen as a response to their work to have a better structure and a better way of working forward to develop a licensees forum. Most of the safe communities, certainly in New Zealand, have an alcohol stream, and I think that's a place where some responsibility to deliver the projects or programs and to identify some of the risk is important. And I think sometimes that we're looking for that magic answer. We're searching away up in the sky somewhere looking for it, but it actually might be right in front of us. And I recall having a conversation with a friend of mine a couple of days ago and saying, back to about the 1980s, I think, when Jefferson Saunders did some work in Britain, that perhaps the basis of that is still valid today, and I think that we could better use that. And effective enforcement is key to reducing harm. Certainly, literature out of the ACT shows that that has a great effect, and we certainly are trying to apply that in New Zealand as well. New Zealand has a new law, and it's fully implemented in 2013. It provides for local decision making, so local district licensing committees will be in place to start to make some of those decisions, and they require good information for sound decision making. And when you start to look at some of the terminology in the legislation around harm minimisation, around the effect on the good amenity, and some of those other terms that are used in the new legislation, then communities can make a difference, because they will be able to influence those local responses by making sure that the district licensing committees are not just supplied with information around an application, but some broader information that will help reduce those problems. And I think that there's been examples of that in the health sector, particularly where they've developed information for district licensing committees to look at health-related harms and how that can be responded to. There's also an important piece in the legislation around parental supply, and I think John talked about that quite early on. And in New Zealand, as from the 18th of December, it'll be an offence to supply a minor with alcohol, and without the express permission of the parent or guardian. And the guardian is not the coach of the local rugby team, but is a legal guardian. And there's some work going on in that area that communities should be engaged in, and they can use some of that material, and I'll come back to that in a minute, but there'll be some material available for communities to use. Also in the legislation for the first time is a definition of intoxication, and I think that it's really important that communities line their ducks up so that they're all talking from the same song sheet. And the national campaigns around Say Yeah Nah, around parental supply, I know that the organisation in New Zealand that manages that is looking for local communities to take on board something that can have a local content. So just this is something that is available that you should, people could have a look at and could utilise. It's been produced, as you see, by 4 organisations and gives a common focus on the definition of intoxication and how that can be managed. And similarly, the Say Yeah Nah campaign by the Health Promotion Agency, they're wanting to share that with communities. So again, the messages out there can use some of that terminology. So my conclusions really are that sometimes we forget about what is working and we don't look at some of the really good things that we've got together. Working together is incredibly important, and we need to be part of supporting the legislation. A lot of focus has gone on local alcohol policies, but they'll all be done and dusted shortly, but the legislation and district licensing committees are there for a long time to come, and you should be influencing those. And make sure decision makers know about the issues, particularly the harms, so that can be reflected in local decision making. Thank you very much, and there's my contact details if anyone wants to get in touch with me.
Thank you, Laurie, for that really informative presentation. We have one question for you. Do you have any research or know of any research related specifically to smaller communities? And is there a correlation between smaller communities and larger communities in relation to alcohol-related harm?
Well, I think there are a couple of pieces, Alan, around that. One is that I think some of the stuff around the density issue that the Health Promotion Agency funded recently out of Waikato University is one useful tool. And the other area to have a look at is on the Ministry of Justice website, because as a result of the changed legislation, they did some research around risk-based fees. And as an example, they can they determined, for argument's sake, that a nightclub is 22 times more likely to have problems than a restaurant. And if you, for every hour that you open after midnight, you increase the number of incidents by 2.2 times, and that gets progressively worse as the time goes on. So there are a few of those examples now that have emerged as a result of the new legislation, getting ready for the new legislation. And I'm certainly, if someone wanted to email me, I would provide them with a couple of links to that, but the Health Promotion Agency would be another place that would help.
Thank you, Laurie, for that. And yeah, and thank you once again for sort of putting in the time and sharing your thoughts on this important topic. We're now going to hand over to Michael Mills from Tauranga. And bear with me for one moment while we just change this over. And we'll make him the presenter. And we'll just, one more little. Okay, Michael, it's now up to you if you'd like to share your presentation with us, please.
Have you got me there?
Yes, we have.
Well, greetings everybody from the city of Tauranga in the Western Bay of Plenty. That's a town on the east coast of the North Island of New Zealand. Just a little bit of background. We have a population of 116,000 plus 45,000 in the surrounding Western Bay of Plenty district. It's a rapidly growing area, and 15% between 2001 and 2006 and around 8% since 2006. It's a retirement destination, and the number of older people is projected to overtake the number of young people in the next decade. But having said that, we have a burgeoning youth population here, so we have we're weighted at both extremes in terms of age. Tauranga is situated on an extensive harbour. It's guarded by the iconic Moa, or commonly known as the Mount, and it's a major tourist destination. Did I mention it's a beautiful place? Well, this is Tauranga, our city, and the area that I'm referring to today is over here along the foreshore on the harbour. The other views are of the beaches and the port and what have you. I want to talk about taming the war zone. Now this is the war zone. Sorry, some of those pictures are a bit blurry. This area here is called the Strand. It's a indoor, outdoor, daytime, nighttime, dining, restaurant, bar area, and it's not uncommon. Many cities have these areas. Ours is in quite a picturesque setting on the edge of the harbour, separated from the water by a railway line. Over here you'll see on the right-hand side. This building in the bottom left-hand corner is brand new and represents quite a bit of reinvestment that's going on in the precinct. And actually, down at this far end of the building on the far left-hand end, there's a wonderful tapas bar, and if anybody pays a visit to our beautiful city, I'll be happy to host you for a meal there. Well, anyway, our war zone, I called it, and when I arrived in Tauranga in 2006, this was the kind of headline that seemed to be appearing in the paper almost every week. Gang bloody brawl, 16 arrested after liquor ban breaches, 9 arrests after a near riot. I don't know how a riot almost breaks out, but a riot almost broke out. Teen stabbed with bottle, night of drunken mayhem on the Strand, 2009. Drunken brawl blocks the streets and city centre. 2 brutal assaults, 2010. So we had a well-documented and well-publicised war zone going on on the Strand. But there was another war zone that also had to be addressed, and this was the war zone between the police, liquor licensing, the city council and the licensees. Look, they were all at odds about what was happening, who was to blame and what needed to be done. And the allegations flew. Media reports were catastrophising the situation. Statistics were being used and challenged and refuted. Our politicians were certainly of mixed views on what to do and what needed to be done. And when the pressure came on, everyone resorted to their respective corners and came out swinging. So this was really the first challenge. If we were going to address the issue on the street, we had to address the war zone between the agencies that had responsibility to deal with it. So finally in 2010, all the parties were brought together to thrash out a comprehensive plan to overcome the recurring issues and to create channels of communication rather than resorting to the media, which was tended to be what happened. And so we had a variety of parties coming together there, councils, Safe City, Main Street, the Hospitality Association, and a number of the Strand licensees. And a key outcome was identified by the partners, and that was that the vitality of the Strand at night is maintained through a collaborative partnership that takes into account public and personal safety, business responsibility, maintenance of a safe and clean environment, and monitoring, management and regulation. And under each of those 4 headings, there are a series of bullet point actions that fell out of the plan. I haven't included those in this today. So some of the actions that did arise out of the Strand Night Management Plan. No more liquor licences after 3 AM, new or renewal. The problem that created there was that we had one nightclub that had a 5 AM licence, and so come 3 AM you got this migration of people down the road queuing up in the street to get into the later night or early morning venue. So solving that helped a lot. Increasing the liquor ban, we had a partial liquor ban in the CBD, but that was increased to a 24/7 across the whole of the CBD. That made a huge difference, because that meant that young people, particularly underage, who would come down with carrying their alcohol, would sit on the grass, sit in the park, sit in the car park and drink and be part of the atmosphere of the Strand, but totally drinking in an unsupervised way. So the liquor ban made a big difference. Closed the reclamation car park. Now this is the car park on the other side of the railway line from 10 PM on a Thursday, Friday and Saturday night. Now this prevented people congregating in what was a very hard to manage setting and drinking out of the boot of their car and generally having issues around in what was not an easily managed place. Along those lines, we removed the hedging along the railway line boundary fence, and that increased visibility right through. And finally, moving the pedestrian footpath to the outside of the pavement. What we had was a situation where the footpath literally went between the outside licensed areas and the indoor licensed areas, which meant that pedestrians, including young people, troublemakers, or anybody else happened to want to wander through, was literally wandering through a licensed premises, and the licensees were very unhappy with this, so eventually the footpath got moved. We improved the lighting on the philosophy that light attracts people but dark attracts crime, so we made sure that the areas we wanted lit and managed were much improved, and we positioned and improved the quality of our CCTV, which is monitored on a Friday and a Saturday night. We provided and still continue to provide bar and door staff training. This generally raised the standard, and we no longer refer to people as bouncers or that kind of terminology, but they're actually door staff and are trained accordingly. We provided Mellow Yellow, which was a campaign I think started in Manukau in Auckland, where door staff were given fluoro vests to wear, and this again was a way of marking out their authority and their role as security in those environments. We subsequently have provided radio communications between door staff and between them and the CCTV operator. This has meant much earlier warnings and interventions when potential problems arise, and the bars and the licensed premises really love having the radio communications. We also put resources in the bars with key messages around personal responsibility, because at the end of the day, while the licensee has responsibilities around serving intoxicated people and so on, it's not always easy to know when you've got a bar full of people. So we were encouraging people to take more responsibility for themselves and their friends, and the police have set up a dedicated policing team, which has meant, again, that they're proactive, they're more visible, and it's made a big difference. This thematic map shows where the offences were occurring over the past 5 years, and as you can see, the Strand is at the centre of that here, and then it radiates out through the CBD. An analysis of alcohol-related offending in the CBD says there's been a steady reduction in the last few years, although there was a slight increase last year. But the police report that overall the feedback from their staff is that the area was much, much safer than it was previously. Tauranga City Council supplied this data, which is drawn from the CCTV monitoring. You'll see the orange columns down here relate and pretty much mirror the council, the police figures, but the blue one here relates to the reported incidents as recorded by the CCTV operator. So that's made a big difference, as you can see, in a big drop-off in incidents that the CCTV operators had to deal with. So the key elements, where do we go to from here? The key elements of this Strand Night Management Plan have largely been implemented. So in 2013, earlier this year, the Council adopted an expanded CBD Night Management Plan that takes into account other night users of the CBD, and this would include movie theatres, any other agencies that could be, any other entertainment theatre and so on. Tauranga Safe City has allocated funding to undertake a comprehensive safety audit using sort of basic CPTED principles as another component in this. And the City Council is currently deliberating on its local alcohol policy that will set rules and conditions on location, density and hours of operation, and looking likely to set one-way door restrictions for later in the night. The Tauranga licensees are proposing to establish an accord, just as a way of working together more effectively and contributing to the wider partnership. And Tauranga Safe City and other agencies will continue to provide bar and door staff training and support responsible management practices. So look, that's the case study that I wanted to share, and if you want to get a hold of me, I'm Mike at taurangasafecity.org.nz, and thanks very much.
Thank you, Michael. That's excellent, and I'm really pleased to hear that the war zone is being tamed.
Yes, very much so.
There's been a number of comments have been made, Michael, just in relation to changing the word bouncers to door staff. Where did that originate?
Well, it originated from the bar and door staff training that we ran, and the facilitator was saying, look, you need to start thinking of your door staff as front of house, as the host, in a sense, as your welcoming person at your door, and not think of them as simply being there as muscle or security or as a bouncer. And that really did a lot to change the mindset for the, for the staff.
Yeah, it sounds excellent. It's a really simple idea, but very, very effective. And one final question for you comes from WA. Could you just talk briefly about who took the lead role in bringing the key stakeholders together to address the issues around your war zone?
In the end, it was done by the City Council, by the licensing staff at the City Council.
Okay, all right, thank you. I'm just going to bring everyone else back online, so if I could just bear with me for 1 moment. I'll bring, and if we could all share our webcams again. And one more. Here we go. Beautiful. Okay, we're all back online, and I'll just take that back. Okay. On behalf of the Australian Safe Communities Foundation and Safe Communities Foundation New Zealand, I'd like to thank Michael Mills, John Tumbaroo, Laurie Gabatis, and also Ruth Barker for their wonderful presentations today. This has been a really, really useful session to have, and I'm quite sure lots and lots of people have actually got a lot out of it. We had over 65 people watching today, so I'm quite sure there's a lot of interest in the sort of work that all of you are doing. So on behalf of everyone who's been watching today, thank you to all of you, and we wish you a safe season ahead of you, and look forward to further developments in the new year. So thank you one and all. Bye for now.
Thank you.
Bye. Thank you.